Fowlers, ideally Fowlers or high Fowlers, okay, because it decreases the risk of maceration. What is that?
Sorry.
Sorry. So we want to ask some questions before we get started. First question, when they order to insert an NG tube, is you want to know if the patient's at risk for having esophageal varices, right? So have you ever had a history of esophageal varices that anybody's ever diagnosed? Or
Nope.
varicose veins inside your esophagus?
No.
Do you have a history of drinking?
No.
No. Do you have a history of liver failure?
No.
All those questions revolve around asking if they have esophageal varices. Someone who admits to be an alcoholic, a routine drinker, someone who has liver issues, both those patients have portal vein hypertension. It'll cause black flow of the blood, causing the veins inside the esophagus to dilate. Then as I'm putting the NG tube down, I could tear one of those veins, and it's not like a regular cut, right, where you can just hold pressure. It's inside the esophagus. How do you hold pressure inside the esophagus? You can't. They may die on you. Okay, so if the patient has a history, esophageal varices, liver disease, or alcoholism, you will refuse to put the NG tube down. And as a patient advocate, you will have someone from ENT, ears, nose, and throat, come up with a scope, and they put it down. They might laugh at you like, that was so simple. I'm like, yeah, thank you. Now my patient's not dead, and I don't have to worry about it. I don't really care that I bothered your day, right? So many nurses are concerned about that. Lisa, why are you sitting? Are you comfortable?
No, I'm not, but
You
I
don't
didn't
look
want
comfortable.
to. I didn't want to raise up and mess up the video, so I'm trying to become more comfortable.
We want to measure our length. On this, you have your suction port or your administration port. It's the clear port. It's either for decompression, we can suck stuff out of it, or we can put stuff into it. Right? That's the clear port. This blue port is like the sky, not today, but some days the sky is blue. The only thing goes through here is air, right? No medication goes through here. You don't aspirate through here. This is a port. So when you're hooking up the stomach for decompression, the stomach starts to shrink, right? And then all of a sudden it's going to be on. Oh, that's kind of funny. And it holds it in, and then you won't get anything out of the NG tube when you're decompressing. This lets air in so the stomach can re-expand. Does that make sense? And so that has to stay patent. Nothing goes through there except for air. Okay, blue air, nothing else through there. Okay. Also, you'll see a lot of people do this when they want the patient to walk around. That's not good either. You never do that. How are my aides? How many times have you done this to your patients or seen your patients have this done? There's a special apparatus, which doesn't come in our kits. Okay, it's clear on one side and blue on the other side, and it's closed in the middle. And that's the special apparatus that we need to use, not this one. This one's patent. This just opens up vial and catheter contents are going to go in the blue port and occlude it. You do not connect them together. You will see when you guys go to the hospital in 3 weeks, everyone does this. This is wrong. They should have specialized connectors. Okay, half blue, half white prevents stuff, anything but air getting in the blue port. Okay, we have to measure the right size on Advent. This chip. Are you looking comfortable? Are you uncomfortable?
Yep.
Is that better?
Yep.
So to measure, guys, we go from the nose, to the ear.
Let me take my glasses off.
Oh, you're okay. To the xiphoid process. There? Okay. So we're at 75. I can note 75, or I can take an indelible marker, permanent marker, and mark it. Okay. I'm going to document that it's at 75 in Abby's case in the computer. Okay. Guys, do I have sterile gloves on? I touched this to Abby, right? Is Abby sterile? Are you sterile? No.
I don't think so.
It doesn't have to be. It's going into her stomach. Is the stomach sterile? The candy I just gave you guys, right? That Brittany ate 16 pieces.
I had 3.
3. Okay. Is not sterile. I then we take our towel, and there's a decent chance. Did someone get more candy? There's a decent chance that Abby will puke during this procedure. 50-50 patients puke, right? So I put the towel there to kind of protect her, and then I also give her this to hold for holding. If you're gonna spew in this, and we know that movie.
Oh shoot, I can picture it.
5 inches, perhaps.
Her face.
Okay. The other thing, she was getting worried that it was gonna go, and she's like, "Oh my God, he's gonna do it." Yeah.
Never mind.
The other thing is, I would have Lisa or a partner have a glass of water and a straw. So imagine come over with a glass of water and a straw. And what we're going to do is, Abby, the most difficult part of this is from the nose to the ear. That's where it's uncomfortable. Okay. So I insert it from the nose to the ear.
So it goes to your ear?
Yeah, it follows your nares. It goes into your nose, back to your, not your ear, but I'm
canal
saying the nasopharynx area,
towards
Okay.
towards the ear.
So it goes like back
It goes straight back.
It goes
right?
straight
Not
back.
like to the.
Okay.
It goes into your, it's your anatomy,
Okay.
right? Because of the nasopharynx.
Nasopharynx,
So it gets there, get to the nasopharynx.
laryngopharynx.
So we get there, right? And now we have the cup with water, head down, because when you do CPR, which way does the head
just
go?
put up your nose.
Up.
When you do CPR, head goes back, right?
Yeah.
So why do we do this?
So that you
To
don't
close
have-
off the airway and go into the stomach, right? Abby, is that uncomfortable? Yes, it is, and I want her to drink water, okay? Guys, it's not like, relax, it's not like, tilt your head forward. Get your head forward all the way. Now chug water. That's what we want to have happen. We want it to go in the right spot. We don't want to go in the lungs. If you find that you can't breathe during this procedure, raise your hand. Okay. Ready?
Do you drink water?
She's gonna
With
chug
a
water.
straw?
Chug.
With a straw.
Through a straw.
Yeah, suck through a
Oh,
straw.
okay.
Right, so I can hear now she's sucking, 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 sucking. And I keep on advancing. Guys, I'm going and I can't advance anymore. Stop. I can't advance more. Lift your head. Are you okay?
Yes.
Okay. Give it a moment. We're going to bring the head back down again. Lisa, water stuff.
Water.
I'm going to twist a little bit back and forth. Kind of just rotate it. And keep on going. How will I know if I'm in her lungs?
She can't raise.
She will raise her hand. What does that indicate to you? That she can't breathe. What should I do?
Pull it out.
Should I just stop or what should I do?
Wow.
Stop and pull back till I get to the nasopharynx. And then stop there. Let them breathe and recover. Does that make sense? Nose to ear to xiphoid process for measurement, right? History of esophageal varices, chin to the chest, sucking water. Like guys, I want them to finish a whole cup of water by the time I'm done, okay? And then hand up if they can't breathe, because I'm in their lungs, okay? Now other places the NG tube can go. Coil around in the mouth. It'll pop out of their mouth sometimes. And again, pull back, stop, let them breathe, re-attempt insertion. Okay? It's weird when it comes out their mouth. Okay, they have a weird sensation. I also sometimes tell patients this can end up in your mouth. So if you feel in your mouth, raise your hand. Right? It lets me know that something's going wrong. Pretty easy to insert these. Okay? It's easier than a Foley catheter. The Nares, that's actually a big hole to hit. Right? Some other questions you might want to ask your patients besides the history of esophageal varices. Have you ever had an NG tube before?
No.
If they have, let's imagine that you have, which Nares was it in?
The right.
Okay, so I know the rate Nares is patent. I'm going to use the right again. If they haven't, I would ask them to include each Nares and see which one has better airflow. That's the one that we want to use. So include your right Nares, breathe, and include the left one. Which one do you feel like you breathe better through?
Right.
Okay, so now I'm going to use the right one that gets me to know it's probably patent all the way down. Okay. Once the NG tube is in, it's going to... Is that okay?
Yep.
I need to then check for proper placement. Okay, I want to check for proper placement before I secure it in place. We drop 30 cc's of air. I go to the blue port. I inject 30 cc's of air. That causes the stomach to balloon out for me. Does that make sense? I go over to the clear port. I draw up 30 cc's of stomach contents. You guys okay with that? Set that there. Take a pH test strip. Over top of the wash basin or top of the kidney basin, whatever you might have, you squirt it, you check the pH. What's the pH of stomach content? Gastric content? Less than 4. Less than 4. It's acidic. Your intestines and your lungs will be around 6. So if you're getting a measure around 6, you've gone too far or you're in the lungs. I've never got to the point where I actually check fluid from the lungs because the patient usually they can't breathe, right? So at that point, right, so I've never, that's an approved technique at the bedside. The gold standard is an x-ray. Right, so if we're gonna administer tube feed through this, I'm gonna wait for my x-ray. If I'm using it for decompression, if the pH is good, and I can hook it up to suction before I get my x-ray because I know that I have stomach content, especially when it starts flowing out into my suction canisters, right? But for feeding, I absolutely need to have the radiograph before I start feeding because I don't want to start feeding into the lungs. It'd be very bad. But for aspiration, if I get the right pH, I can hook up and then retroactively get my chest x-ray. But we don't want to wait 30 minutes while the patient's, I'm going to vomit, right? That's the whole reason to put the NG tube down so they quit vomiting. Once I confirm placement with a bedside test, is it okay if I put tape on your nose? Okay, she's like, oh, I guess I'm willing to do that.
So where you start
long
putting
as
in
it
is where
didn't go
you marked.
Yeah, so I marked it on her, it was nose to ear, desire for fibrosis. Take the piece of tape and I make a pair of pantalones. See my pair of pantalones? One leg is smaller than the other. It is on her nose. I can put tincture of benzoin on her nose, increase the stickiness of that. Does that make sense? Then I go to the 75, and this would be up on her nose, and I take one of the legs. Lisa, can you give me a hand? I take this piece of tape and just curl it around. And then that other piece of tape comes, thank you. Curls around the other way. It stays like that. Okay. Now, it's usually hooked up to a suction canister feeding. We'll show you guys how to do that on Thursday. But if it's going to be clamped, if these two devices are connected with a specialized device, right? The way we like it so it doesn't pull on the patient. Because we don't have excoriation of the nares, skin breakdown. We take tape and we make a little flap on it. Then I would get a safety pin, I would safety pin it to her gown. When you do this, guys, a lot of people want to safety pin it like down here. You want her to be able to move her head every which direction, so I safety pin up here. Does that make sense? Questions about inserting into emesis basins? Guys, a kidney basin is never an emesis basin. Use a wash basin. Put a chucks on top of their chest again or a towel. Right. Do that. Take off the tape, 2 deep breaths, on the second exhale I pull out. And